Welcome to Eye Contact. I'm Sean Henahan. Today we're talking with Milind Pande about lens-based presbyopia correction options, in particular the EDOF IOLs. Welcome, Dr. Pande.
Thank you. Thank you for inviting me.
EDOFs are the newest entry in the battle against presbyopia. How do they compare to what came before? How have these presbyopia options evolved?
The first options for presbyopic lenses that came through were bifocal lenses. Essentially, they split light into two foci, and in between the two foci, there was a big dip where the vision wasn't very good. Then came the trifocals, and then the EDOF. So the whole idea of the EDOF lenses is that you get a continuous range of focus from distance to whatever point of near vision that you can get to. So the advantage is with EDOF lenses, one, the contrast is better, similar to what you get with a monofocal lens. You get a continuum of vision, so it's a seamless, continuous range of vision, which is more natural for patients rather than having dips in their vision at specific distances. And that really is the key advantage of these EDOF lenses.
Now, one reason people have been hesitant to use multifocals in the past has been problems with glare and halos, photic phenomena. Is this any different with the EDOFs?
They're thought to have less photic phenomenon than other multifocals, although you might be able to show that on a test bench, but the perception of dysphotopsia or photic phenomenon depends not just on the retinal image, but also on how patients neuroadapt to these. There is no optical system on the planet which gives a completely sharp focus without any aberration or some kind of deterioration at some level of magnification, and hence it's the same with these things too. The key really is, what we find is 99% plus patients easily adapt to these kind of photic phenomenon, provided they're expecting them from the pre-op counseling. The trouble starts when it comes as a surprise. So it's very important to tell patients upfront what is the kind of vision, the quality of vision, the range of vision they can expect to get.
Who are these lenses intended for? Who are the ideal candidates?
These lenses are intended for anyone who wants to see better without glasses. That's the bottom line. I see EDOF lenses, trifocals, monofocals as just different tools in my toolkit for treating presbyopia patients. So I start with a particular framework which we identify as that's the target we need to get to our patients. And then start with, most of the times, an EDOF lens, because I think that gets nearest to that marker. And then we have a specially developed framework of functional vision assessment, which we call the panfocal visual acuity testing, which allows us to test objectively where the gaps in their vision are, how well they perform at certain tasks in the clinic, and also a questionnaire feedback from the patient. So on the basis of these three things, we then work out a strategy for the second eye to try and improve things further. Either we fill the gaps in, or if the halos are too much, we try and use a different type of lens in the other eye to reduce the summated halo phenomenon. If they want to read better, you would use a different type of lens which would emphasize that.
Really?
So binocular customization of lens, defocus, torus, are all features and tools which we use to maximize the benefit for our patients, because there is no single lens which gives you perfect vision at every level of illumination, at every distance, without any halos. We would love to have that, but it doesn't exist. So we have to use lenses and tweak them, either in terms of the refractive target or different light energy distributions in each eye, to try and get to that holy grail of complete spectral independence.
Well, let's reverse the question. Who are the worst candidates for these lenses?
The worst candidates for these lenses are patients who are not bothered about wearing glasses. That's the bottom line. Patients who cannot accept that they will not get perfect vision. So if patients expect that they'll get the vision of a 21-year-old, it's not happening. Engineers, teachers, surgeons, type A personalities who like extreme control of every aspect of their lives expect every last second to be absolutely correct. They struggle to accept the limitations of what this kind of technology provides at the moment, and hence they're not good candidates for them. It's not for them. In which case they have to accept the compromise of wearing glasses. So it really is, it's a trade-off in the sense that it's a trade-off between three things: the quality of retinal image, the quality of vision, the dysphotopsia as such, and the range of focus. And it's a juggling act between these three things in choosing what kind of lenses and what kind of patients.
Well, let me follow up on that. How often are you doing some kind of micro-monovision when you're using the EDOF lenses?
We use a different term. I think we need a different term for EDOF lenses, because when you do the calculations, the effective defocus customization, and I have a paper on this, is only about half to three-quarters of a diopter between the two eyes. And that's not really monovision, because when you look at the literature of monovision, what we find is that the difference between the two eyes has to be more than a diopter in order for the binocular summation to be affected. So if we keep it less than that, it's well within the normal physiological differences that we see within eyes, and hence I've coined a term which I call nanovision rather than monovision, just to differentiate between the two, that this is a physiological level of difference that we put in. And what we find when we look at the data is that, in my experience, if you look at a lens performance, which is defined as a lens visual acuity profile without any residual torus or defocus, then 100% of patients with EDOF lenses get distance vision, intermediate vision of 6/9 or better. About 2/3 of patients get to 6/9 or better for near in good light, and about 1/3 of patients get for 6/9 or better for near in poor light. But that's the monocular effect. So when we start off, we need to find out which patients land in which category, and then design a strategy for the second eye. And nanovision is a very common strategy that we use in order to achieve that.
And what about the distance vision? How do they fare?
Very good distance vision, similar to what you get with a monofocal, although they do see halos, and the halos are similar to any of the other presbyopia lenses.
Interesting. Thanks so much for sharing your insights.
You're welcome. Thank you. Thank you for the invitation again.
Thank you for joining us. For more information on this and related topics, please visit us at eurotimes.org.